Welcome to this episode of NLN Nursing EDge Unscripted. I'm your host, Dr. Steven Palazzo, a member of the editorial board for Nursing Education Perspectives. In this episode, we will examine the guest editorial, Putting Wheels on the Tradition, Reimagining Innovation in Clinical Education. This work is authored by Dr. Donna Badowski, Founding Director of Nursing and Vice Dean of the School of Science, Engineering, and Technology at St. Mary's University in San Antonio. Dr. Badowski also serves as Innovation Center Editor for Nursing Education Perspectives. This guest editorial appears in the January-February 2026 edition of Nursing Education Perspectives. The editorial emphasizes the need to innovate clinical education while preserving the value of traditional clinical experiences. Dr. Badowski notes that simulation, community-based learning, and other non-traditional models have advanced nursing education, but hospital-based clinical practice remains essential because many new nurses enter acute care. Rather than retiring traditional clinical education, she positions it should be reimagined. Well, welcome, Dr. Badowski. We're very excited to have you.
Thank you, Dr. Palazzo.
So let's just get off on some of the questions here right away. So you discussed that traditional clinical experiences should be reimagined rather than retired. What wheels could nursing programs add to strengthen faculty-led clinical education while preserving the value of the bedside education?
So first of all, I just want to say that bedside learning does remain the foundation of clinical learning. And the impetus for me writing this article was I belong to a consortium here in San Antonio, and the issue is with not having access to electronic health records, or some hospitals not even allowing nurses to even administer medication. And some hospitals where you can only have 2 students here and 2 students there, and that leaves faculty, and that really leads to more of a preceptor-led model, which might not be the case for an early nursing student. So we need to kind of present ourselves as, programs of nursing to these hospitals, and so that we can remain as a unit, like 8 to 10 students on a unit, where faculty take the lead, so to say, so that they're actively coaching and questioning the students instead of placing them with a nurse to follow them along throughout the day. So some types of wheels that, might be considered, and that, I haven't really seen, because a lot of the articles written are about community-based learning or simulation, and those are all great, but we need to really reinvent what's happening in the clinical setting. So perhaps maybe a midday huddle where, the faculty will pull the students and do a midday huddle. We always start with a pre-brief in the morning, and we end with the post-conference, but maybe we need to meet in the middle sometimes of the day, or faculty rounding with the students are other options. Or if it's a facility that doesn't allow students to administer medication, maybe there could be some sort of guided medication reasoning that is done during the clinical day. They observe the nurse administer the medication, since the faculty is not there, but then the faculty can pull that student aside and do some sort of guided medication reasoning, either before or after the medication administration, or ask the student, what type of patient education would you provide if you were administering this medication? Mock administration when access is limited. We don't need the simulation suites to provide simulation. We can bring those simulation tools to clinical and maybe do some sort of mock simulated medication administration in the clinical setting.
All good points you raised there. You also mentioned in the editorial that preceptor-led models may shift teaching responsibilities to already overtaxed nurses who are working in the units. So how can nursing programs balance that preceptorship partnership with the need for direct faculty coaching, questioning, and assessment of clinical judgment?
Yeah, that's a great question. And I am not anti-preceptor. As I mentioned earlier, I really believe the novice nursing student requires the mentorship of their faculty. Our bedside nurses we know that they're overwhelmed in the clinical setting. They have high patient loads. They have a lot of things on their plate, and now to take the time to coach and guide a novice nursing student might not
Hmm.
be the best learning experience for these students. So I'm not anti-preceptor, but maybe that's should be safe for our senior level nursing students. Could be because, nursing staff exposure is valuable. I mean, these are experienced
Right.
nurses working at the bedside, and, students can actually follow by observing. But to me, a preceptor-led model is that staff nurse actually um, watching a student do these types of skills. And again, and we know when students are doing skills, things are a lot slower. So that kind of will put that staff nurse behind and start creating anxiety and have them feeling overwhelmed. So again, this is why I really believe it would behoove nursing faculty to rethink, and put wheels on that clinical day in the clinical setting. I love all the different articles out in community-based
Hmm.
settings as well as simulation, but now let's focus more in the clinical setting. And there really isn't a lot out there about innovations of clinical teaching itself in the traditional environment.
Yeah, there's not, and not a lot of data either,
No,
which is
there
just
was that
amazing
MT
how long we've
review.
been, yeah, how long we've been doing clinical education and just not having good data to, I mean, there's not even data to correlate with, the amount of time or hours spent in direct patient care,
Right.
at the bedside and outcomes.
Right.
Um,
A lot of boards of nursing don't even define the number of
right,
clinical.
right.
It's whatever hours you think is going to help
Exactly.
the students meet the competencies. And if we're not really studying that, how do we even know as faculty?
Yeah, I suspect because it's hard variables to measure, um,
You're right.
that it probably dissuades a lot of people from looking at that as a research endeavor.
Hmm.
Boy, it definitely seems necessary. Well, maybe a
Right.
scaffolded approach, thinking about a scaffolded approach from reliance on more clinical faculty, cognitive development of students early on, transitioning over to a preceptorship model when they get to their internship, semester.
Right.
And what
Because
does that
remember,
look like?
faculty have the educational expertise,
Right.
and the preceptor has more the practice
Hmm.
expertise. So, those novice nurses really need the guidance and coaching
So
from,
how do we bring the three together? Like I think of it as the practice piece, right, that the nurses at the bedside have, that psychomotor piece that's at in simulation, and then that, experience, cognitive, clinical reasoning piece that our faculty bring, and marrying those three together into some kind of scaffolded approach, you know, is one way that I got out of reading your editorial.
yeah, simulation provides a great opportunity for the deliberate practice of skills.
Right.
And even in my role as a director in doing our advisory council meetings, I so often hear from our clinical partners is we can teach them the technical skills. We need you to teach them those softer
Right.
skills, such as communication and clinical judgment and clinical reasoning. And it is challenging, but
Hmm.
that's why I'm kind of created this article to push our colleagues to be innovative. And
Yeah.
they probably are, but they're not sharing that innovation. So this is a great opportunity to write up a nice article to share among their colleagues. And then maybe, either the originators of the innovation or someone else could take it and start studying it to see if it really is making a difference.
We touched on simulation a little bit, but as I was reading through the editorial and got towards the end there, you brought in, which is kind of on everybody's mind right now, right? Uh, Technology, especially artificial intelligence. What is that going to do, and how may that help faculty focus on intentionality of reasoning, judgment, and patient advocacy? Like, what safeguards are needed to ensure that these tools, like these AI tools that are developing rather rapidly, um, rather than replace the human experience of nursing education, and the dimensions of nursing education, how can they enhance it? And we probably don't know
Well,
yet necessarily what
yeah,
it's going to look like, right?
right. Well, we have to really understand that AI is not going away.
Oh, no.
We know that there's already AI robots in some facilities. Moxie is what I'm thinking of.
Mm-hmm.
And I know there's some companies that are working on actual nurse robots.
Yeah.
But again, as you mentioned, they can't replace the human side. So we need to teach our students how to work with and know that it's not going to take over the human touch, the human connection that we have with our patients. And it might take over some of those technical skills. So that more better place for us to really work on those softer skills to, have our students become stronger in those skills. Clinical judgment, advocacy, empathy, they all require human interaction, not robotic interaction. Now, AI can, again, because it's so new, it's something I know that I will use, for example, when I'm creating an escape room. I teach
Mm-hmm.
healthcare informatics. I'm not even in the clinical setting right now. But if I want to create an escape room related to some sort of informatics competency, I will use AI because it can help me create an escape room a lot quicker than I can.
Right.
But I know that it makes mistakes. So I have to keep
Mm-hmm.
working with it and say, this doesn't seem right. There seems like a missing piece. And I feel that the same thing can be done in clinical education if, there's a lot of downtime in the clinical setting, and maybe nurse faculty can turn to AI and reach out and say, I've got this clinical day, and let's say OB. I know that there's a lot of downtime sometimes. I remember doing clinical one time when there were two mother baby couplets and I had 10 students.
Wow.
And it was a 12-hour clinical day.
Oh,
So,
a lot of downtime.
so that's where, maybe AI can actually, come in handy to give that nursing
Mm-hmm.
faculty ideas for clinical learning in that environment, in the actual traditional clinical environment.
Well, your editorial brings up some very important points that will get us all thinking. I want to thank you for joining us today, Dr. Badowski. I want to remind the listeners that the article is Putting Wheels on Tradition, Reimagining Innovation in Clinical Education. And I want to thank also Dr. Badowski for her work as an editor on the Innovation Center of Nursing Education Perspectives. There's a lot of work that goes into that, so we appreciate the time and effort you
Thank you.
put into that. And again,
And I
thank
want
you.
to thank you for inviting me to this podcast.
Oh, absolutely. It was a pleasure to have you. It's a great topic, and it's something we need to think about.
Thank you.